Welcome back, everyone. Today we have a very special video. We're going to watch in real time my self-surgery that I did on myself last year. In tooth number 30, I took out tooth number 30, and then I followed it up with an immediate implant placement. And so I haven't seen the video. We're going to go through this together. We're going to share in this experience together. And in my video, editor told me to tell you that she wasn't present during the actual footage. So this is all footage from all of my team members, all kind of mushed together into one video. So here we go. Let's get started. Successfully fractured from the mesial to the distal of tooth number 30. And it is going to be taken out today and hopefully replaced with a dental implant in a matter of minutes. So here we go. So I'm in my surgical suite, and I'm going to take this opportunity to kind of sense what it's like to put pressure on a tooth that's not numb, because I've always wondered. Yeah, it's broken pretty good. Okay, so I've always wondered what it would be like to put a 23 cow horns on a molar. So I'm not numb. I'm going to go ahead and see what this feels like. Yeah, so the background to this is, so that before I tell you what happens here, the background to this part right here is that I was actually really resistant to the fact that I'd broken my tooth. So I was being very stubborn. So it had been about 6 months that the tooth was fractured before I actually got after it. But by that time, it had actually gotten pretty sore. So it was the sensitivity of the tooth was pretty high. So at this point, when I got into the 23s, it didn't take much for it to feel pretty intense. So let's see what else happens here. Hurts like a son of a gun. Yeah, yeah, that hurts pretty good. I think if I was lost on an island with an ice skate, I could get it out. But that's pretty hard. So I'm not done. I'm going to give it one more try. It's throbbing pretty good right now, but we're going to go ahead and try one more time here. So I honestly think that maybe if I had tried it earlier before I let it get that infected, that I might have been able to do it. Oh, yeah, that sucks. Yeah, it definitely sucks. So the mesial cusp is broken off and is down below the gum line. So when I put pressure on it, the periodontal ligaments are just on fire. So we're going to go ahead and put a little numbing action in here. And I'm not going to do this myself because there's no way I could do a block by myself. I tried to do the block, but I couldn't see. My hand was in the mirror. So the hand was in the way. I couldn't see what I was doing. So I said, yeah, I'll go ahead and let my wife go ahead and get me numb here.
All right, Dr. Rob, go from wide.
She did a great job, of course. Better give some props. Okay, so we're about 20 seconds into the block, and I can already feel it. Of course, the tongue is already numb because she hit my tongue, so she hit the lingual nerve. So yeah, that sucker's really nice and numb, but the block is already kicking in. But there's no joy here. No joy. It's all work. So I like to kid with my wife, and she doesn't like to kid back.
Yeah, I got lots of joy here.
I've always wondered how much time is necessary to allow a block to really become effective.
Yeah.
So this would be a nice experiment for me, but I can already feel it working within seconds. I actually can feel it, so that's kind of interesting. Yeah. So people say, well, why did you do that? I mean, why did you start off with, let me try to take the tooth without any numbing agent? Well, honestly, we haven't had numbing agent very long, right? So we haven't had lidocaine for a whole long time. I mean, even when I was a child, it was Novocaine, right? Before that, it was nothing. And so I really wanted to see what was the dental history like prior to, the invention of these local anesthetics. And no wonder the literature is just riddled with, toothaches were really bad, and it was even worse to go to a dentist historically, because, I mean, when that tooth is sore and it's inflamed and then you put pressure on it, it hurts like a son of a gun. And so no wonder they were biting bullets and drinking alcohol, because that thing hurt. So I can see that. So I wanted to sense that. That's the first thing. And the second thing is you don't know, you have feedback loops in dentistry. So when you give someone a local, you say, well, I'm going to wait 3 minutes or 5 minutes or 9 minutes. You're going to wait some period of time before you're going to proceed with the procedure. But when you do it yourself, you actually can measure how long it takes for that reaction. So I felt the lingual nerve go numb within 20 seconds.
I thought that's really interesting because I didn't realize it was that fast. You know, when I give an injection, I don't expect it to actually kick in that quickly. But that really changed my perspective when I was able to feel that on the lingual within 20 seconds. That was pretty fast.
So I'm using the Pat Allen end cutting instrument from my soft tissue kit to go ahead and incise the perineal ligaments around the crestal region.
So we're attempting to do this without elevation. So just releasing the crestal fibers there with the Pat Allen end cutting instrument.
Yeah, I'm not numb. Yeah.
Yeah. So yeah, I'm not numb there, but we're going to proceed because we're stubborn.
Yeah, that hurts.
All right, so block 2.
Open really one.
And she's going nice wide and high on this one. She's going to get it this time.
About 4 minutes, from 4 to 5 minutes from the injection. Tongue is really down. Lingual nerve is good, but I was able to get some pretty good pressure on with the cow horns. So I'm going to wiggle on this a little bit.
So I had a big bathroom mirror that we just put on the
So
wall.
what's happening is I have such large tori. I'm not getting into the focal space with the cow horns because there's so much bone in the way.
You want a 151?
Yeah. So that was Sarah, as my surgical assistant, asking if I wanted a 151. The tooth cracked mesially distally down a virgin tooth, which is just crazy. I mean, the force is, I have massive tori, so much stress. Pretty sure it's from being married for 30 years, but I'm not sure. She's not here to answer, so we'll just leave it as it is. But so I was having a hard time getting the cow horns to actually go into the focal space because the lingual and buccal tori are just so big, and you can see that in the after photos. They really are really high. They're in a coronal way, very difficult to get to. All right, so we got part of the root out. People ask me, why weren't you wearing gloves? I'm like, it's me.
Lingual cusp out.
I thought I had 50-50 chance. If I wore gloves, half you guys would say, I can't believe you're wearing gloves and you're doing your own work. And if I didn't wear gloves, half you guys would say, I can't believe you didn't wear gloves, that you didn't wear gloves, So I there was no way I was going to win on this one. So I went with no gloves.
When that tori is that high, you won't be able to get into the focal space to get the 23s on there. So I think we're going to have to abort and go to sectioning the tooth, which is what you would do normally right out the gate, but we're having fun here.
Yeah.
So
I'm having fun.
What we're going to do now is just going to wait. And we're going to let the hyaluronic acid do its job and release, because I've traumatized the tooth. So the perineal ligaments are going to start to release here. So we're just going to wait a little bit before we go ahead and section it. We're ultimately going to have to section this tooth to get it out, but I'm just going to wait because the roots are so long. I don't want to break off a tip deep, because if we break off a tip deep, then we're going to have to dig for it. If we dig for it, we run the risk of not being able to get primary stability on our implant, because we're going to follow it up with an immediate implant. So we've waited about 8 minutes after the first trauma to the site with the forceps. We're going to come back and see if we got any extra movement now.
I look like a Bell's palsy here. All right, so we went with the 151s now to get on the remaining cusp. We get some good movement. And so as you guys know, with regards to extractions, once you get good movement, all you got to do is not break it, right? You're going to win the day if you just take your time. Oh, I just broke it.
That's what I was worried about.
So I just
Not what I
separated
wanted.
the last buccal cusp. That sucks.
Yeah, because now you definitely have to go in and separate the two pieces, right?
But we haven't moved home. Let's give it another 5-10 minutes, and then we'll go ahead and section it.
So we have both roots loose. We'll just put a little bit of pressure on that.
So I wasn't able to do this part myself. We went ahead and
That baby will
the
roll
roots
right out of there.
were fractured when I was on it with the 23s. And so we're getting in there and we're just elevating it with the 301 and getting those root tips out.
Look at that. She just delivered a little tiny Robert.
It's a nice curved roots.
Yeah.
You'll be able to see that in the on the images that we share with you guys.
Just doing the same thing, just putting a little bit of pressure
So going into the distal aspect and then elevating towards the mesial into the focal space.
there. Exactly what I was gonna say. Stop
And I
making
didn't
fun
have
of
any pain here at all. We didn't use a bite block because the forces weren't so much that I needed any sort of support. If it was a patient, if I was working on a patient myself, I would always use a bite block on the lower to prevent any sort of potential trauma to the TMJ. This is one of my favorite little burrs. It's a long, skinny burr with diamond on it, and it works great for troughing. It works great for separating teeth. Because it's long and skinny, you can use it in the anterior for sectioning anterior teeth if you need to. It's a great little tool.
It's just stuck in the hole.
And then this is a double-ended root tip pick. It's also one of my favorite instruments because this one's by Hugh Freedy, and it's really beefy. And I actually use the root tip pick quite often as an elevator, as a little micro elevator. So we get it into the periodontal space and then rotate it slightly just to get a little movement. So it needs to be beefier. If you use one of those skinny little ones, you'll bend it right away and they'll all be bent. All right, so the tooth's out. The furcal bone was intact. We're proceeding with a type 4 surgical guide. This is a keyed system, so I'm looking in the mirror again, placing the key, placing the drill.
Yeah.
Assistant's holding the guide down on my chin, and I drill a hole in my head.
Yep.
Okay.
But see, the suction is what I was worried about. So we either need to turn the water down or off, or you're going to be covered in blood.
Oh.
So I said, turn the water off, because you don't really need water. When you're going guided, the drill happens so fast, it doesn't really affect the temperature of the bone.
I've already spit on everything.
So hard to look in the mirror with your chin down and keep the fluid in the back of your mouth. So I'm kind of drooling all over myself like a 2-year-old.
Like a, you got it? There you go. Give it a wiggle. There you go. Yep.
So easy a monkey could do it.
Down on this side.
No, so easy a caveman could do it.
Yep, you're
You're
down,
down.
all the way down.
Do it here.
And the other thing is that I wasn't able to wear my normal spectacles. So like,
He's not down.
without my spectacles, it's just difficult to see if the guide is, if the depth position, the collar on the drill was all the way down. So I was asking for confirmation from my team, and they were giving me verbal confirmation.
Go ahead.
So the implant's going in.
Can you grab the green section, Dr. David, and get right at that guide sleeve
Pardon?
stop positioner?
Oh, I had no feeling at this point. There was no pain whatsoever.
Yep, go.
This is just mechanics, really. Quite honestly, there was no pain at all through this whole process.
Keep going.
And oddly enough, I didn't even take an ibuprofen the next day. There was zero pain.
18
So
Newton centimeters, the primary
the problem is I have a high tolerance for discomfort.
Give him a good rinse.
So I can't say that would be for everyone, but I will say that I was surprised that I had zero pain. I thought I'd have a little something, but I literally had nothing. And that's something I really don't feel like I can carry over to most patients. Maybe it's just placebo. Maybe they just feel like they should be in pain, so they give more feedback because historically we've had more discomfort reported to us from patients than what I felt for sure.
Position. And using the 5-thread rule, we were able to get primary stability. And we've got a tall healing abutment on because I sunk this a little bit deeper, not calculated deeper, but because my tori had grown up over this space, the effective depth was deeper. But the interesting thing is we didn't graft it, and we're doing a little experiment to see how well this heals around this implant with a rather massive gap. So we'll see if we can close down about 3 to 4 millimeters worth of space as it heals.
Okay, so what we did there is we placed the implant and we did not gap graft. And normally what we would do is we would gap graft between the implant and the avellus. We would graft that with normally with mineral loss, which is a corticocancellous autograft, or allograft rather. And we didn't do it in this case because I really wanted to reproduce some of the research that Dennis Tarnow did on the canine that he extracted, placed an immediate implant. There was a 4 millimeter gap between the buccal wall and the implant. And then subsequently, the patient was willing to let that implant be removed, trephined out, and then studied under a microscope, and he had bone that had grown up against the implant. And when I had heard that study, and Dennis refers to it as the gift, when he lectures on it, he talks about the gift because this gentleman was willing to do this for science. The dentist went back, grafted, he came back and placed another implant, and the patient was fine. But the purpose was to look at that implant under the microscope and see if bone grew up against it and not soft tissue invagination, and that's exactly what he got. And that was a paradigm shift for me, because when I read that paper and then I saw him lecture on it, it really changed how we do dentistry, because prior to that there was, in the industry there was a huge push for, if you don't have a barrier membrane, you're going to have soft tissue ingrowth, and that's just not something that we see. So that was the start of it, and what I did is I reproduced it here, and if you get to see the after photos here, you'll see that it actually did knit in with bone just like you would expect. So no soft tissue ingrowth, and the reason is that soft tissue can't grow through a dead clot. There's no blood supply, so it can't grow through there, and that's exactly what we got. We had 100% success. So.
All right, so the experiment's over. We got tooth number 30 out. We got the implant in. We got a healing abutment on it, and it's healing just fine. It's been about an hour since the procedure's been over. Most of the numbing is gone, and I'm having zero pain whatsoever. So this is going to be an interesting experience. As you can tell, I'm talking normal. I'm having no bleeding or anything. So I'm really looking forward to tracking this over the next couple of days. This is going to be very helpful for how I manage my patients going forward.
And I really do believe it has been. So from having no pain, really immediately even after, I think I took maybe one ibuprofen that night just as a precaution to be ahead of the game, but I didn't really need it. And then healing without any sequela. I will tell you that within about 15 days or so, I felt like I could eat on that implant. I mean, I put my tongue over there and I felt soft tissue around the top, and it was stable, and I could really see how people would be fooled into thinking, maybe the doctor doesn't know what he's talking about. I'm just going to bite on this metal because it feels really rigid. And that was really within like just a little over 2 weeks, kind of pushing up on 3 weeks, where I felt like that implant could be used. And it was really hard to stay off it. So that was one thing. And then keeping it clean was quite readily easily. I mean, it was very simple to keep it clean afterwards. So initially, no cleaning of the healing abutment, but after a couple of weeks, we started cleaning the healing abutment, and it stayed perfectly clean all the way to the end. So the patients that have come back with cupcake buildup on top of their abutments are clearly not following the instructions, because my healing abutment came out with nothing on it. So with just a little bit of effort, a toothbrush with no mechanical motion, just turn the mechanical part off if you got a mechanical brush, and just kept it clean, and it was fine. So we ended up restoring it about 3 months later, and I haven't had a single problem with it. So it's going really well. Screw retained monolithic zirconia, just like we do 98% of the time. This has been another episode of Implants Made Simple. I'm Dr. Robert Stanley, the Smile Engineer, helping you re-engineer your practice every day.